that, there are a few questions I'm sure that are burning on a few of your minds. Even though I'm sure that, like Dr. Lynch said, all of you already have a concern and are concerned, members of the medical community, when it comes to health equity. There are still people who wonder, why are we still talking about issues of diversity and inclusion and cultural competency? I mean, we live in a world in where it is unlawful to discriminate against others based on a number of protected classes. Aren't we living in a post-racial society, given that we now have a black president? A few years ago, I litigated a case in where a gentleman who was a member of the Sikh religion wanted a religious accommodation so that he could wear his turban while also serving in the police department. That was 8 years ago, and since then, our workplaces have become much more open to the idea of offering different accommodations for people based on their religion and their disabilities and so forth. Today, we had a number of students who helped out, who came from a population that at one time was thought of as a population that couldn't contribute fully to our society. When I saw this advertisement in my local Target newspaper, I realized that the community with different abilities has definitely come a long way. So why are we still talking about these issues, given that all of these advancements have taken place? Well, because we understand that there are still those who do harbor bias, discrimination, and harassment. That top article was an issue or an incident involving Abercrombie & Fitch. Some of you may remember or recall the incident where some geniuses over at Abercrombie thought it would be really cute and funny to create these shirts that said, "Two Wongs don't make a white." And they had a series of t-shirts that were very anti-Asian. Journalism, which is supposed to be one of our most objective professions, recently, or I should say a few years ago when they were covering the Katrina hurricane and the Katrina catastrophe, had a very interesting moment where they had to take a moment of pause. You see, you had two different sets of articles, but with very similar pictures. In one set of the pictures, you have a black person who is wading through water with items of food. Then in another picture, you have two people, Caucasians, who are also wading through water with food. However, in one article, the individuals are looting, and in another article, the individuals are finding food. I'll leave it up to your best guess as to who was finding food versus who was looting. Back when I was presenting many of these programs to corporations and law firms, I would always look at our society as a whole in order to create the context within which we're talking about our workplaces, because the two cannot exist without each other. And I would look at healthcare, and I was always stunned to see the numbers of disparities that we still had with diabetes, with heart health care, with cancer. And all of these disparities ran along racial lines. The idea that Hispanics have a higher likelihood of mortality because of diabetes in the year 2010 was startling to me. The idea that the risk of extremity was 2.5 times the risk of the regular, or pardon me, the other population, our majority population, that also struck me. My self-interest. I know many of you are also wondering, how is an employment attorney so concerned about health? Well, at the end of the day, we're all going to have to present to all of you with our health conditions. And I want to make sure that the person who sees me as a patient and a person and not a statistic. Recently, the Dana-Farber Institute had a study, and their findings were that African American women were less likely to receive the same therapies as our Caucasian counterparts. And we're talking about in a population with insurance. So I started looking a little bit deeper within healthcare. And at the time, I was doing a great deal of research and finding out or trying to determine what creates barriers to inclusion on a professional level. And it just didn't even dawn on me to even look into the healthcare professions until I started talking to some of my colleagues who were anesthesiologists, who were specialists in a number of areas, people who went to the creme de la creme of schools, people who were the ostensibly most intelligent people in our societies. Yet their careers were sidetracked somehow because they didn't receive the mentoring that they noticed that their other counterparts received. They didn't receive the same training, the same kind of one-on-one approach that their colleagues received. And I thought, you've got to be kidding me. Within healthcare, people go into healthcare to save lives, to help improve our outcomes. I come from a medical family as well, and where my mother cared for other people as a registered nurse for, and I don't want to tell her age, but for about 30 years, she was a registered nurse. So I started digging once again a little bit deeper, and I noticed the startling statistics when it came to the enrollment of African Americans and Latinos in medical school. The idea that these two populations, which are growing populations in our American demographic and particularly in Connecticut, the idea that they make up less than 20% of our medical community, people who are going to medical school, didn't really sit well with me. So the question is, why should we care about cultural competency and diversity within healthcare? What are our motivations to do this? Similar to the legal profession, you needed a business case to really get different people to the table. Oftentimes you have the same characters who are showing up to the events, or the same characters who are caring about this issue. But the people who really do need this training, the people who really do need to have these conversations, often don't come unless there is some sort of business motivation. Normally I show a slide that indicates that the Level the Playing Field, which is a not-for-profit based in California, they did a survey and they found that workplace unfairness, whether it's discrimination, harassment, bias, you name it, but the general category of workplace unfairness costs U.S. employers $64 billion annually. Now, $64 billion, that's the annual revenues of Google, Amazon.com, Goldman Sachs, Starbucks combined. That's a lot of money that you're throwing out the window. The U.S. Veterans Administration, an organization, once again, that's in the business of saving lives and ensuring that our veterans have proper health care. They did research and they found that they had higher incidences of workplace violence than even the U.S. Postal Service. They knew something had to be done. So they started looking at civility, and they noted that civility is a part and parcel with cultural competence. You can't have one without the other. And they found that they found that the more that they were able to increase the civility and cultural competence of their staff members, they were able to reduce tardiness. They were able to reduce workplace violence issues. They were able to create an environment where people wanted to come to work. They also did some research and found that the patient outcomes improved when you had environments where people worked as a team and they collaborated and they worked together. They found that the patient stays, or the number of days that a patient would stay in the ICU, decreased when you had greater cultural competency amongst the medical providers. The U.S. Veterans Administration has 5 hospitals that have achieved Magna status. Of those 5 hospitals, 3 have instituted a cultural competency training program that's incredibly robust. So with that, I continue to ask the question, what is the business case for diversity within healthcare? So joining me to create a multidisciplinary approach to attacking this question, I've invited a number of different people to the table. To my immediate right, we have Dr. Atik Mirza, who's a very successful doctor based in Hartford. He works for St. Francis Hospital. We have Geraldine, who's a member of our New Haven community, who is a part of an amazing documentary, and you'll see part of it today. We have Dr. Wayne Rawlings, who is a doctor who studies healthcare disparities at Aetna. We have Judy Tabar, who is the president and CEO of Planned Parenthood of Southern New England. Mary Merwin, who is a clinician with Asian Family Services, and Mary Gambardella, my fellow employment lawyer from Wigan and Dana. All right, so Mary, I spoke about some of the healthcare disparities amongst the Latino and African American communities, but we never really hear about disparities when it comes to the Asian community. I understand that the Asian Pacific community is growing within the state of Connecticut. Between 2001 and 2005, that community grew 30%. So this is a population that definitely deserves our attention. Does that community suffer from any sort of health disparities that we should know about?
Well, I do apologize. When you said health, I was thinking of health, not so much in mental health, but if I talk about mental health, yes, definitely there is disparity in that we don't have enough mental health services for Asians and that'll be the end of the story. If I may say, Asian Family Service is the only licensed mental health clinic in the whole state of Connecticut that provides linguistically and culturally appropriate counseling services to Asians. And if Asians are to have the same proportion of people suffering from emotional difficulties or mental illness, then there would be about 25,000 people, but there's no way we can accommodate that many people at Asian Family Services. So there's a disparity, and there's lack of mental health services, but also talking about health issues. Asians have intentional and unintentional underutilization of health care, leading to poor quality of health of individual and also quality of life and also of family members. And I don't want to go, you don't want to tell me what just contribute to that, right?
I'm sorry?
You don't want me to talk about what contribute to underutilization at this time?
Please, feel free to share.
I say intentional, and that's my own language, but Asians are generally reluctant to seek outside help. They try to resort to home remedies, so to speak. You may have heard of coining, but because of their belief in the etiology of disease or illness, they try to use herbal medicine, coining, which is to restore the imbalance of the energy in the body, to drinking certain soup, not like Jewish, but they have specific chicken soup and also hot and sour soup to remedy certain symptoms. And again, they're very reluctant to use Western medicine. And unintentional is probably just similar to other racial groups and immigrants, but lack of knowledge about healthcare system and the language.
Okay.
So
given
there are many issues.
All right, so given that, so let me play devil's advocate for a moment. So if we're to say that the language barrier is an issue and lack of education, I would also say that there's probably an issue of, health insurance. So I'm going to turn to you, Dr. Rawlings. If this is just an issue of health insurance, we shouldn't see healthcare disparities amongst your population, people who are insured by Aetna.
Thanks. As you said, disparities in healthcare exist in America in a variety of spaces and areas. In the national examples, as you said, are around invasive procedures, cardiac procedures.
Yeah, your mic's on.
It is.
If I speak, can you hear me now? Let me, all right, if I thank you.
Oh, no, actually, we do need you to mic, yeah.
How about now? All right.
National disparities exist all around invasive procedures and cardiac interventions and curative lung cancer surgery, pain medications, the emergency room, which are well documented in the medical literature. We've been doing a lot of work around understanding disparities as they exist in the insured population, and we see them. In fact, it's very important to understand that healthcare disparities in the United States don't only exist in the uninsured population. There are clear examples of disparities in the insured population. Some of the work that we've done identifies differences in hemoglobin A1C, which is a measure of diabetes control, with high levels being bad, low levels being good. We see more African Americans and Latinos having high levels of hemoglobin A1C, which is bad. Poor control means they have more, we will have more complications from diabetes just related to that. There are differences in emergency room utilization in asthmatics, or differences in adherence or compliance with medications. So the important thing that I think it's for people to understand is having insurance does not make disparities go away 100%.